So this area is coronary artery disease, and one of the important aspect of evaluating coronary artery disease is stress testing. And stress echo has assumed significant importance because it's quickly done and it's less expensive than some of the other stress testing modalities, such as nuclear stress testing. So stress echo is very common. You can do it in the doctor's office, and a lot of hospitals are now changing over to stress echoes. So when we talk about coronary artery disease, so we're talking about obstruction or blockage of the blood vessels around the heart. So you have to know the anatomy of the blood vessel around the heart. You know, as we said, there's one on the right side, we call the right coronary artery, that comes off the right coronary cusp. And then on the left side, uh, we have the left main, which comes off the left coronary cusp, and that divides into a left circumflex and a left anterior descending coronary artery. You have to have a basic idea where on the heart these blood vessels travel to and what area of the muscle they supply blood to. Because when someone presents with a blockage, say they present with a heart attack, it's usually in one of these blood vessel distribution. It's very rare that someone presents with a heart attack and a cross distribution. When you present with a blockage, an acute occlusion, or even a chronic occlusion, usually either the right coronary artery, the left anterior descending coronary artery or its branches, or the left circumflex coronary artery and its branches. So, you know, it's not usually two or three. So by knowing the coronary artery distribution, that is where in the heart these blood vessels supply blood to, um, you can either look at your EKG or you can do a stress test and determine which blood vessel is occluded. So the stress test, um, brings out the blockage, so to speak. So, for instance, you have an obstruction. So you have a blockage inside the right coronary artery. So you know the area in the heart muscle that the right coronary artery supplies. So at rest, the echo might look normal, but once the patient is exerting themselves and is under stress, then the blood flow to that area cannot keep up to the demand. So what you will see is a wall motion abnormality related to the distribution of that blood vessel. So that area will not move and thicken as it normally would under resting condition. So you need some type of stress when you're doing. You need to stress the heart. So you can stress the heart by exercising, or you can use and when you exercise the individual, you can use either the treadmill or the bicycle. in the western part of the world, we use a lot of treadmill, but there are institutions that use bicycle. It's a supine bicycle. Or if the patient cannot exercise for whatever reason, you can use a chemical stress. And the most common chemical stress is the dobutamine. You can use persantin or some other similar compound, adenosine. So you can use either persantin or adenosine. But the most common stress is the exercise, which is either the treadmill or the bicycle. And the treadmill is the one that we use a lot of time. The bicycle is a supine bicycle, and there are different what you call now energy level. So the bicycle is a little bit different from the treadmill. With the treadmill, we have different protocols. You can use a manual protocol, you can use a Bruce protocol, you can have modified Bruce, you can have Norton. So there's all tons of treadmill protocols. The most common one is the Bruce protocol, where every 3 minutes you increase the speed and the inclination of the treadmill. So every 3 minutes you move from a different stage, and you should at least know the first 3 stage when you're doing the Bruce protocol. You might get questions related to that. When you start the Bruce protocol usually start with an inclination of 10 degrees. That's the treadmill is inclined at 10 degrees, and the speed is 1.7 miles per hour. Second stage is 12 degrees, and you increase the speed to 2.5 miles per hour. And then stage 3 is 14 degrees and 3.4 miles per hour. Okay, so you need to know at least the first couple. In order for the stress test to be valid, we try to achieve what we call 85% of the maximum heart rate. And the maximum heart rate is 220 minus the patient's age, and we try to achieve 85% of that maximum. However, there are some protocols that you will see they talk about a submaximal stress test, where the goal is 70% of the maximum heart rate. So that's a submaximal stress test. And we will do this for patients who had, say, they may have a heart attack. The heart attack is not very extensive, and then we want to see if there is a lot of underlying blockage. So before they leave the hospital, we'll do a submaximal stress test. So the goal there is 70%, not 85%. And then with the dobutamine, we usually start the dobutamine, low dose dobutamine, and low dose dobutamine is 5 micrograms per kilogram per minute to 10 micrograms per kilogram per minute. So the low dose is the 5 and the 10 micrograms, and that is where we will do another. So we'll do an echo at rest, okay, in both the exercise and the dobutamine. We'll do the echo at rest, and then with the exercise stress echo, we'll put the patient on the treadmill or the supine bike, and then once a patient achieves maximum exercise, then with the treadmill, we'll take them off the treadmill, put them on the gurney, the bed, and then repeat the imaging. All right, so that is your stress image. With the dobutamine, it's different. The patient is lying on the bed, so you will do your resting images. You'll do your resting images, and then every 3 minutes you increase the dose of the dobutamine. You start with 5 micrograms per kilogram per minute, then you move up to 10 micrograms per kilogram per minute, then you move to 20, you move to 30. Most protocols go to 40 or 50, okay? So there's no protocol that I know of that goes beyond or above 50 micrograms per kilogram per minute. So most protocol will go to 40 or 50 micrograms per kilogram per minute. So one of the protocols with the dobutamine, you're going to get your resting images. Then you get the low dose. The low dose is between 5 and 10. Remember, the low dose is between 5 and 10 micrograms per kilogram per minute. And then you get the peak image. And then recovery images is done 10 minutes after the peak. So once you do your peak and you turn off everything, the recovery image is done 10 minutes. So you'll be familiar with the protocols a little bit. All right, so again, this just go over the coronary distribution, and you have to have a rough idea of the coronary distribution. So remember, this is your short axis at the apex, short axis at the mid-level, short axis at the basal level, and this is, if you look at this as your parasternal long axis. So again, at the apex, your anterior wall, inferior wall, septum. So you see the LAD. So these are the blood vessels, okay? And then the distribution on the different cuts in the heart. So at the apex, the anterior and the septum is supplied by the LAD. The inferior is by the RCA, right coronary artery. At the middle level, the anterior and the septum, a portion of the septum, the anterior and the anterior septum, LAD. The inferior septum and the inferior wall, the RCA. And then the circumflex supplies the lateral wall. And then for the basal level, it is pretty similar to the mid-level, okay? The parasternal long, you have the circumflex supplying the septum, the posterior wall, and then the apex is by the LAD. So have a rough idea. You know, we commonly say that the anterior wall LAD, inferior wall RCA, lateral wall left circumflex. So just you know, a rough idea, because then they're not going to give you anything that's too complicated. So when you do your stress test, so if you do your exercise stress echo, so you either the treadmill or the supine bike, you're going to get your resting images. So you get the echo at rest, and then you exercise the patient. Once you achieve your exercise goal, then you get your another set of images, and then you do your interpretation. Okay, say we do let's do exercise stress echo to start with. So at rest, if the walls are thickening normal and moving normal, then it may be normal as well as it could be abnormal. So remember, at rest, because the patient is not, the heart is not under any type of stress, the blood flow may be adequate for the proper functioning of the muscle. But once the patient exert themselves and the demand on the heart has increased, then the blood flow may not be sufficient to match the function of the heart muscle. So the heart muscle is not going to move properly. You're going to get decreased thickening and sometimes decreased movement as well. So what you're supposed to get in a normal individual is a normal echo at rest. And once the patient stress themselves because there is no obstruction to the blood flow around the heart muscle increase activity. We say it's hyperdynamic, and this is normal. So at rest, the walls, the muscles are moving normal, thickening, and the motion is normal. Once the patient do their stress either on the treadmill or the bike, then the heart muscle increase movement, and the thickening is increased. And we usually say that in a normal individual, they should get an increase in ejection fraction by 5% or more. So you're looking for an increase in ejection fraction 5% or more. Okay. So you're not only looking at the different segments or regions, but you're also going to evaluate the overall ejection fraction. So again, if the wall motion is normal at rest, I think, normal thickening, normal motion, and then with stress or exercise, the one area of the heart muscle is not thickening or not moving properly. This is classic ischemia, okay? Classic ischemia. So normal at rest, there is a blockage of the blood vessel supplying that area, and once the patient exerts or stress themselves, the blood flow to that area is not sufficient to meet the needs, so that that muscle do not thicken properly and do not move well. So this is what we call ischemia. You can also get another form of ischemia if the patient start out with wall motion at rest. So say for instance the muscle is hypokinetic. It's not thickening and it's not moving well. But when you exercise them, it gets worse. So that could also mean ischemia. So ischemia just means obstruction to blood flow, and then the heart muscle is not getting sufficient blood flow. You can get a situation where there's wall motion abnormality at rest. So there's hypo or akinesis at rest. You exercise them to the max, and there is no change with the exercise image. So that could represent an infarct. Remember, dead muscle, when we talk about infarct, we talk about a dead muscle. Infarct or dead muscle cannot contract. It's not going to thicken. Okay? So if there is, and what you're looking for is thickening. You can get movements because the normal muscle may pull the abnormal muscle and give you the impression that it's moving. So movement alone is not what you're looking for. You're looking for thickening in the muscle. Dead muscle do not thicken. Dead muscle do not thicken. So if you have wall motion abnormality at rest, and then you exercise the patient and there is no increase, then that's an infarct. Or if the muscle is akinetic, that means it's not thickening at all at rest, and then you exercise the patient and it becomes dyskinetic. Remember, when we say dyskinetic, it moves in the opposite direction to what it's supposed to move in. That's also infarct. And then in this scenario right down here, we talk about at rest, there's wall motion abnormality, and then it improves, it gets better when the patient exerts themselves. This is what we call cardiomyopathy. So the difference, cardiomyopathy could be ischemic or non-ischemic. So you can have heart muscle weakening because of blockage of the blood vessel around the heart, or you can have heart muscle weakening because the heart muscle is diseased. So when we talk about just the cardiomyopathy right here, we're talking about a non-obstructive cardiomyopathy. So the heart muscle is just weakened because of alcohol, drugs, viral infection, whatever. So in those individuals, you'll see probably an ejection fraction 40% at rest. You exercise them, it might improve to 50%. Okay, so you have to think in terms of just cardiomyopathy. I left the biphasic response for last because this is what you're going to get with a dobutamine. You'll get this with a dobutamine stress test. And that the dobutamine stress test has the advantage of looking for what we call viable myocardium. Viable myocardium. And what we mean by that is when you see someone with, say, an ejection fraction of 40%, some of the muscle is going to be dead and some of the muscle is going to still be alive. Okay? Okay, some of the muscle will be dead and some of the muscle is going to still be alive. So, but you have to do some form of test to show that that's the situation, that's the case. Nuclear stress tests, you can do nuclear stress tests to determine if there's viable muscle in, say, someone who have an ejection fraction of, say, 20%. And, so you have someone with ejection fraction of 20%, and they have a lot of blockage of the blood vessel around the heart. You can do, say, bypass surgery, or you can do angioplasty and stenting, but you don't want to do those procedures if all the muscle is dead and the patient is not going to improve, because you're going to put the patient through open heart surgery, which carries a certain amount of morbidity and mortality, and then they're not going to improve. As a matter of fact, sometimes they get worse because there's no viable muscle there. And if they went through the stress of having bypass surgery or angioplasty and stenting, the heart needs to increase the output so the patient can survive, so they can do worse. So it's important for you to find out that patient with an ejection fraction of 20%. Do they have viable muscle in that 20% ejection fraction? Because if they do have viable muscle, once you increase the blood flow to the heart muscle, then the ejection fraction gradually increase. So it might move from 20% to 40% or more, because there are viable muscle there. And once you increase the blood flow to the muscle function improves or increase. So that's the importance of the dobutamine. One of the importance of the dobutamine stress test. So if you have someone, say, ejection fraction 20%, let's use 20%, they have a lot of blockage of the blood vessel around the heart, and you want to see if that individual is going to improve the ejection fraction. If you do bypass surgery, you can do the dobutamine stress test. So at rest, the ejection fraction is 20%. When you give low dose dobutamine, so remember the low dose is between 5 and 10 micrograms per kilogram per minute. If there is viable muscle, when you give the low dose dobutamine, the ejection fraction may increase to 35, 40%, like that. And then when you give the peak dose of dobutamine, the ejection fraction will fall back to, say, 20%. And then recovery, it may remain 20%. That is what we call a biphasic response. Biphasic response. And biphasic because with low dose dobutamine, the ejection fraction increase, and then with high dose or peak dose, the ejection fraction decrease. So it's a double response, biphasic response. Increase ejection fraction with low dose, and then with higher dose, the ejection fraction fall. That suggests that there's viable muscle, because the dead muscle do not contract. Dead muscle do not contract. So the only reason, or the only reason why you're going to get that increased ejection fraction, because the muscle that's there, that's alive, once it gets increased blood flow from the low dose, it's going to increase its contractility. Okay. We talk about hibernating myocardium, and that's when you have low blood flow. When you have very low blood flow, some of the muscle might hibernate, just like a bear hibernate. It's going to conserve its energy because it doesn't have, tremendous amount of energy. So it's going to conserve the energy. So the muscle is hibernating. So that's what we call hibernating myocardium. But once you increase the blood flow and it has sufficient energy, it's going to increase its contractility. So the biphasic response in the dobutamine stress test suggests that there is viable muscle. All right, so that is your stress test, and so you need to go over that. You have to understand it fully. Okay, so yesterday we touched on the TI index, and we talked about RIMP, right ventricular index of myocardial performance. We can do the same thing for the left side. So you can assess uh, left ventricular function, both systolic and diastolic function. So it's the overall myocardial function by looking at LIMP. So we're on the left side now, so it's LIMP, left ventricular index of myocardial performance, the so-called TI index. Okay, it assesses the overall myocardial function, both systolic and diastolic. It's a P-doubler measurement. Okay, it's a P-doubler measurement, and we're on the left side. So we're not talking about tract, we're talking about the mitral valve now. So it's from mitral valve closure to mitral valve opening minus the ejection time divided by the ejection time. So it's a similar definition to RIMP, but it's on the left side, so you have to use a mitral valve. So it's LIMP, left ventricular index of myocardial performance. So it's a P-doubler measurement. The sample volume is placed at the mitral leaflet tips, apical four-chamber view, and it is from the mitral valve closure to the mitral valve opening. You're going to subtract from that the ejection time divided by the ejection time. Okay? So this is the definition. And just as I showed you yesterday, if you're moving from the mitral valve closure to the mitral valve opening, so it's all of that period of time, and you're going to subtract the ejection time. The initial part, after you have mitral valve closure, then you're going to have IVCT, then you have the ejection time, then you have IVRT. If you subtract the ejection time, you're left with IVCT plus IVRT divided by ejection time. So this is what it looks like. So when the sample volume is placed at the tip of the mitral leaflet, and you'll get this is your mitral inflow, E velocity, A velocity. Then before you get ejection, you have the IVCT, okay, isovolumic contraction time. Then you have your ejection. Then you have IVRT. Then you have your mitral inflow again. Okay, so the definition is mitral valve closure to mitral valve opening. So this is the flow across the left ventricular flow tract, and this is the ejection time. So you can see if you subtract this from that, you're left with IVCT plus IVRT, okay? And then you divide by ejection time. So again, this is the mitral inflow, ejection across the left ventricular flow tract. You can measure these time interval on your Doppler signal. You can measure it, okay? So you have to know the definition. So index of myocardial performance, myocardial performance index, the TI index, all right. So this IVCT, isovolumic contraction time, IVRT, isovolumic relaxation time. For the left side, it is the normal value is 0.39 plus or minus 0.05. So that's a normal value on the left side. Okay. So the IMP or the MPI increases in patients with all spectrum of heart disease. So it's if the patient have any type of heart disease, it's going to get larger. The number is going to increase. Again, RIMP, which we did yesterday, right ventricular index of myocardial performance, is important in following patients with primary pulmonary hypertension. So it assesses the overall myocardial function, systolic and diastolic. So Um, you just have to, they're not going to ask you anything in detail about it. So you just have to, have a basic understanding of it. Um, so, so, so we can also assess the contractility of the heart by looking at what we call DPDT, and they will they will ask you a few questions about this DPDT. So let's understand what we mean by DPDT. It's a change in pressure with time. So if we're looking at the left ventricle, even the right ventricle, if we're looking at contractility, a heart that is pumping very well should change, should have a fairly large change in pressure with time. So it will generate a fair amount of pressure in a short period of time, as opposed to a heart muscle, which is weak. It's going to take a longer time to generate the pressure. So just sort of think about it. So if say the ejection fraction is 70%, that muscle is contracting very well. It's going to take a short period of time to generate a significant amount of pressure in the LV. Um, so just give me one. A heart that's contracting very well will generate a significant amount of pressure in a short period of time, as opposed to someone, say, have an ejection fraction of 20%. It's going to take a longer time to generate some amount of pressure, and they may not be able to generate a very high pressure in the LV. So DPDT assesses global LV contractility. So it is what we say DP is change in pressure with respect to change in time. Okay? So it's essentially how much pressure you can generate within a short period of time. And it assesses global contractility. So it is the pressure generated in the LV during the IVCT period. So it's the pressure generated during the isovolumic contraction time. Okay? And we usually use MR jet, and we increase the sweep speed to 100 millimeters per second. So it is a C-doubler measurement. Okay, you're going to do MR, mitral regurgitation. You're going to increase your sweep speed to 100 millimeters per second, and it's a C-doubler measurement. You can adjust your velocity to about 4 meters per second. So just think about when you have mitral regurgitation. When you have mitral regurgitation, you have in systole blood flowing from the LV across the mitral valve into the left atrium. Okay, that is the definition for mitral regurgitation. If the heart muscle is contracting very well, that's going to go very quickly. Okay, so because the heart is going to generate a significant amount of pressure in a short period of time, so that that mitral regurgitation is going to sort of go back quickly, as opposed to if the heart muscle is weak, then that same mitral regurgitation is going to take a much longer time. Okay, because the left ventricle cannot generate significant amount of pressure. So it's going to take a longer time to get your mitral regurgitation going. So remember, it's, because they can test you on this, because this is what technicians usually do. So, sweep speed 100 millimeters per second, C-doubler, and you adjust your velocity. So let's look and see how it's done. All right. Before we get to the calculation. So you have your, all right, so let's use the cartoon first. So this is your mitral regurgitation. This is the mitral regurgitation right there. Okay, it's a systolic flow, and as again we say, you it's a CW measurement, mitral regurgitation. Okay, the ECG is on top. So, systole is from the beginning of the QRS to the end of the T wave. So it's a systolic flow. And as mentioned before, this measurement is done during the IVCT, isovolumic contraction time. So customarily, we talk about we talk about 1 meter per second and 3 meter per second. So again, time is on the horizontal axis. On the vertical axis, you have velocity. So we want to see how much time it's going to take to generate a pressure at 1 meter per second and 3 meter per second. Okay? So that's what we're trying to do. We want to see what time it's going to take to generate the pressure from 1 meter per second to 3 meter per second. So these are the 2 points you need. So again, on the vertical axis, you have velocity. So what you're going to do at 1 meter per second, you come across and you have a point on the MR envelope. At 3 meters per second, you come across and you have a point. Okay, so the starting point will be at 1 meter per second. So if you come up, so on the horizontal axis, you have time. So you get a certain time. So from 1 meter per second, so you come across, it intersect the graph right there. You come up and you get a certain time. At 3 meters per second, you do the same thing, and then you come up and you get a certain time. So this little time right here is the time it's going to take to generate the pressure from 1 meter per second to 3 meters per second. Okay? So you can calculate the change in pressure and you can calculate the change in time. As a matter of fact, you can get the change in time from right there. But the change in pressure, you can calculate that. We talk about the pressure at 1 meter per second. So remember the modified Bernoulli equation. The modified Bernoulli equation, the pressure gradient is equal to 4v squared. So the velocity, we say it's 1 meter per second. So the pressure at 1 meter per second is 4 times 1 squared, which is 4. And then at 3 meters per second, the pressure there is 4 times 3 squared. So it would be 3 squared is 9. 4 times 9 is 36. So the change in pressure is 36 minus 4. So the change in pressure in going from 1 meter per second to 3 meter per second is 32 millimeters mercury. So, and this is always fixed because we always move from 1 meter per second to 3 meters per second. So the change in pressure is always 32 millimeters mercury. The thing that's going to vary is the change in time. Again, if you have a strong heart muscle, it's going to take a shorter time. So the stronger the heart muscle, the shorter the time. The weaker the heart muscle, the longer the time. So you should deduce from what I'm saying is that with a normal heart, because this is going to be small, you're going to get a larger dPdt. Okay? You're going to get a larger dPdt with a normal muscle. And with an abnormal muscle, because the dt is going to be longer, you're going to get a smaller dPdt. Okay? So with mitral regurgitation, you get this envelope. Okay, you change your sweep speed to 100 millimeter per second. You do your velocity about 4 meters per second. You get your nice mitral regurgitation. So at 1 meter per second, so this is 2, 4, 6. So 1 meter per second is about right there. Then you go up at 3 meters per second, which is about right here. Okay, you come across and then it's right there, and then you go up. So this little thing right there is a change in time. So you can measure that because it's a time. You can use your caliper and measure the change in time. As a matter of fact, the computer did it for you. The change in time is 67 milliseconds. So all you have to do now, remember the change in pressure is always the same because you're moving from 1 meter per second to 3 meter per second. That pressure difference, modified Bernoulli equation, 4v squared. So at 3 meters per second, 4 times 3 squared, 36. At 1 meter per second, 4 times 1 square is 4. 36 minus 4 is 32. So 32 divided by this little number here. But remember, the definition is seconds. So you have to change this to seconds. Okay? So you have to change it to seconds. So you have to divide it by 1,000. Okay? To get seconds. All right. So let's just go back and so when you're doing your dp/dt, you do your calculation from 1 meter per second to 3 meter per second. It is the time it takes to generate the pressure between the 1 meter per second and the 3 meter per second. It tells you how well the heart is contracting, or the power of contraction. Using the modified Bernoulli equation, pressure gradient is equal to 4v squared with the 3 meter per second. 4 times 3 squared, 36. 4 times 1 squared, 4. 36 minus, so this is supposed to be 32. So, and then this is supposed to be millimeters mercury. So someone was sleeping when they did this. So this is 32 millimeters mercury. 32 millimeters mercury. The change in pressure is fixed. 32 millimeters mercury. You don't have to calculate that again because we have shown you how it's done. Okay, so dp/dt, it is 32 divided by the change in time. The only thing you have to measure is the change in time on your Doppler measurement. Okay, so it is the time. The change in time is the time it takes to generate this pressure. If the heart muscle is contracting very well, it's going to take a shorter time. If the heart muscle is weak, it's going to take a longer time. The normal values for dp/dt is between 1,000 and 1,200 millimeters mercury per second. So it's a pressure divided by a time. And the pressure is in millimeters mercury, and then time is in seconds. Normal value is between 1,000 and 1,200 millimeters mercury per second. Okay, and just go over it. So it's your MR signal, 1 meter per second, 3 meter per second. The pressure difference there, you convert velocity to pressure. You find the difference, and then on the Doppler you can do your time. So this is the actual scenario. So you measure the time from there to there in your Doppler signal, and you'll get a time. So this is the only measurement you have to do. So you go from 1 meter per second, you drop your line, 3 meter per second where it intersects, you drop your line, and then this is the only time you have to measure. Sweep speed 100 millimeters per second. All right. So on the right side, you do the same thing. You need a TR jet, but on the right side, you're gonna go between 1 meter per second and 2. So if you're gonna look at the dp/dt in the right ventricle, instead of 3 meters, you use 2 meters. So the change in pressure is always 12 millimeters mercury. Um, all right. So those are some important points that we went over. When you have a heart attack, so when you have a heart attack, it's a sudden cessation of blood flow to the heart muscle, and the heart muscle dies. When the heart muscle dies, just like anything else, it dry rot, and the muscle can rupture. If you have enough of the muscle dying, then the how well the heart is pumping can be reduced. So we talk about a cardiogenic shock. So cardiogenic shock, if more than 40% of the heart muscle dies, then you can the overall pumping function of the heart can be reduced. Or you can get rupture of the heart muscle. You can get rupture of the septum if that's the area that was involved in the heart attack, or you can get rupture of the free wall if that's the area that was involved in the heart attack. Or if the heart attack involved the right side, the right ventricle, then the right ventricle will not pump sufficient blood into the pulmonary circuit so you can get it back into the left side of the heart. And that also can give you cardiogenic shock. So when we talk about cardiogenic shock, it is because the cardiac output, the output from the heart, has dropped tremendously. So the heart is not pumping sufficient blood out. So that's what we call cardiogenic shock. Okay, so you can get it from multiple complications of a heart attack. So if more than 40% of the heart muscle is involved, the overall contractility of the heart will be reduced. Or if you have rupture of the heart muscle because the heart muscle dies, or if you have an RV infarct, these things can give rise to. So other complications, so we talk about free wall rupture because the heart muscle dies, so it dry rot and it ruptures. You can see a thinning of the myocardium. Let me just go. So pseudoaneurysm, you have this when you have a pseudo, it's not a true aneurysm. When you have a true aneurysm, when we say aneurysm, it's a bulging, outpouching of the heart muscle. So when you have a true aneurysm, it's because the heart muscle dies and it weakens and it bulges out. Okay, that's a true aneurysm. When you have a pseudoaneurysm, it's different from a true aneurysm. Pseudo means false. So when you have a pseudoaneurysm, what happened? The heart muscle actually ruptures, it bursts, but the blood is contained in the pericardium, which is out, just surround the heart. So this is a real dangerous situation because if the pericardium ruptures, the patient will die. So a pseudoaneurysm, there's rupture of the free wall, rupture of the heart muscle. You can see where there's rupture, you see the myocardium is very, very thin. The blood is contained in the pericardium, so you get a pericardial effusion. And then if you put your color flow or your contrast echo, you can see where the blood is moving through the myocardium into the pericardial space. So this is a surgical emergency. You have to repair these individuals. So it's important to distinguish between a true aneurysm and a pseudoaneurysm, because a pseudoaneurysm actually means that the heart muscle ruptures and the blood is just contained by the pericardium. Okay, so this would be a case. So if you look right here, right at the apex, okay, so it's your four-chamber view. So right at the apex, it's rupture and blood is into the pericardial space. So the only thing that preventing exsanguination, when we say exsanguination, the patient bleeding out to death, is this pericardium which contains the blood. So you have to take this patient to the operating theater and repair the rupture, the pseudoaneurysm. And they commonly ask you what's the difference between a pseudoaneurysm and a true aneurysm. And usually, of course, the pseudoaneurysm, you have pericardium, uh, you have a rupture, you have a narrow neck. So this is what we call the neck. Okay, it is from the LV to where you have the outpouching. If you have a narrow neck, it's probably pseudoaneurysm. With a true aneurysm, the neck is going to be large, wide. Okay. Again, you can have rupture of the ventricular septum. Anywhere you have muscle, the muscle can die and it can rupture. So you'll see the septum being thin, and then when you put your color flow, you'll see blood flowing across the septum, usually left to right, because the pressure on the left side of the heart is greater than the right side. So blood is going to flow from the left to right. And you can use your contrast or your saline to show that. So this is a 5-chamber view showing that, there's a rupture right there. You put your color, you can see blood flowing from the left to the right. Okay, so ventricular septal defect. So that concludes coronary artery disease.